And I see how respectful you are becoming. I like this. So it can be fatal, especially during initial oligouric phase. So let me explain what this is speaking about. So most common cause of acute kidney injury in hospitalized patients, so it's in people who are already sick, okay? It spontaneously resolves in many cases, okay? So it can go away on its own in some cases. That's what they want to reach to you. So it can be fatal, in which the patient will die, basically, especially during initial oligouric phase. So especially during the first phase, your kidney is dysfunctional totally. So it will not be able to excrete anything. So if it is not able to excrete anything, we call it oligouric phase. In the near future, I will tell you that the kidney failure, the acute tubular necrosis, has 3 stages. It has like the initiating event, maintenance phase, also called oligouric phase, and polyauric phase. And we will see why. So to start with, okay, so they write, it sometimes can resolve on its own. What does that mean? Does it mean that you make new tubules? Can we make new tubules, guys? Is it possible? Do our tubules proliferate? Can our tubules proliferate? Yes, they can. What is the only tissue that cannot proliferate? Muscle, cardiac, and neurons. Otherwise, anything else can proliferate. So yeah, they can proliferate, but here's the thing. If you have 99% of your kidney dysfunctional, that's too much to proliferate, so you cannot proliferate that. But if you have like an acute injury that destroyed 30% of your kidney, you still have a chance to get your kidney back. So it can be fatal, especially during initial oligouric phase, and the FeNA will be high. Why the FeNA will be high? Because, well, you tell me, guys. During acute tubular necrosis, can your tubules function? Yes or no? No. Do you have more reabsorption or less reabsorption in case of intrinsic kidney failure? Less. If you have less reabsorption, you will have more excretion or less excretion? More or less? More excretion. If you have more excretion, the FeNA will go up or down? Go up. See, the concept of FeNA is not difficult. The moment you grab it, it becomes a piece of cake. So kidney finding, you will have a granular cast, which we saw in the, I show it to you guys. It's this muddy brown cast, they call it. Let me just show it to you again, because actually this is super important too. Muddy brown casts. So you can see it here. This is the muddy brown cast, basically. Okay. So this is the muddy brown cast, and yeah. And why it happened? Because your epithelial cells has basically just, your epithelial cells has died and then started to accumulate inside of your tubules. So this portion just has shifted and moved from here and started moving to other location, as you can see, and went outside of your body. And you were able to see it in the urine. Okay. So next we have the maintenance phase. So the first phase, it's initiating phase, which is due to the acute stress that was on the kidney. You are like, okay, but what is this acute stress that led to this? Well, it could be ischemia or it can be a toxin. We'll speak about each of these in a moment. So that's the initiating event. And then we have something called maintenance phase. So your whole tubules are destroyed. So they cannot reabsorb, they cannot excrete, they cannot do anything. They cannot secrete, they cannot reabsorb. This is your tubule. It cannot reabsorb, it cannot secrete, so it's stuck, basically. Nothing coming in, nothing going out. Yes? And nothing filtered as well. So no filtration, no reabsorption, no excretion. So what is going to happen to the excretion initially? It will be reduced. You will have oligouria. Yeah? Initially, it will be reduced. It lasts for 1 to 3 weeks. In that stage, you have risk of hyperkalemia because remember, we had a hormone who used to function on the kidney and lead to excretion of potassium. Does anybody know the name of that hormone? Aldosterone. Aldosterone used to excrete your potassium to the outside of your body. Yeah? So now you have hyperkalemia, a lot of K. What K like? Hydrogen, yes? Or as I always say, kill her. I'm kidding, KH. So if the K is high, the hydrogen will be high. If the hydrogen will be high, will you have acidosis or alkalosis? Yes, it's acidosis. Okay. So also you will have uremia. Okay, so why? Because you are unable to secrete the substance out. Recovery phase. So in recovery phase, I want you to know that we have 3 functions of the kidney, actually 4. So we have the filtration, reabsorption, secretion, and excretion. The process of secretion will be the first to be regained. Then the process of filtration. So these are the first to be regained. Filtration and secretion. But one function will be delayed, which is reabsorption. So in the recovery phase, you will not be able to reabsorb. So you will only secrete and filtrate. What is going to happen to your excretion, guys? You tell me. You can only secrete and filtrate. You cannot reabsorb. So what happens to your kidney excretion? It's going up. Yes, it's becoming much higher. That's correct. Okay, good. Next thing, we have the following. They write, initiating event, maintenance phase is the oligouric phase, lasts for 1 to 3 weeks, increase the risk of hyperkalemia, which increase the risk of metabolic acidosis. In the recovery phase, I told you that the only dysfunction now is in the reabsorption. So your BUN and serum creatinine falls. Why? Can you reabsorb urea? You cannot, because I told you in the recovery phase, the only problem is reabsorption. So your BUN to creatinine ratio falls. Risk of hypokalemia now happens. But why? Because you are secreting, but you are not reabsorbing. A renal wasting of other electrolyte and minerals occur basically because you are only secreting, you cannot reabsorb anything. Okay, but it can be caused by ischemia or nephrotoxins. Okay, so in case of ischemic cause, it can be secondary to decreased renal blood flow. For example, massive hypotension in the body or shock, sepsis, hemorrhage, and heart failure. All of these mentioned here are examples of pre-renal, renal, or post-renal azotemia. Tell me, guys. Pre-renal. Hypotension lead to pre-renal. Shock, reduced to perfusion, pre-renal. Sepsis, vasodilatation, massive, pre-renal. Hemorrhage, decreased volume, pre-renal. Heart failure, less cardiac output, less kidney perfusion, pre-renal. It results in death of tubular cells, and then they may slough off into the renal tubules. If they slough off inside of the renal tubules, they will make you a brown cast. So they write here, PCT and thick ascending limb of Henle are the most susceptible to it. Is it going to be the medullary portion or the cortical portion? The medullary portion, correct. So the next thing is nephrotoxic. So the nephrotoxic thing, it's secondary to injury resulting from toxic substances. So what are toxic substances? Like aminoglycoside. Aminoglycoside is a type of antibiotic. I want you to know that this drug is also ototoxic, which means it's toxic for the ears. So it can lead to deafness. Also, radio contrast agent. For example, someone who got a CT and then have kidney failure. What's up? It's nephrotoxin. Okay? So the next thing I want you to know is lead. So what is lead? It's a substance that is embayed, especially in old houses. If you have an old house, make sure that when you are doing renovation of the house, when you clear out this lead from the paint, when you are cleaning the paint from the walls, like this type of paint, scratched paint, be really careful, especially if it was before the 1980s in the US. Because before that, this paint was only banned 40 years ago. So after this, now you don't have a problem with this, but if it was older than that, when you remove it, be really careful. Because you don't want to inhale that, and especially you don't want the child to inhale that, because they are going to get lead poisoning. Okay, so now we see the following. They mention, they are writing about ischemia secondary to renal blood flow. Oh, no, we saw that. Now nephrotoxin, injury resulting from toxic substances like aminoglycoside, radio contrast agent, lead, and cisplatin. Well, cisplatin is a chemotherapeutic agent that can lead to dysfunction of the kidney. Well, ethylene glycol. Can someone remind me about ethylene glycol? Where is it found in? The antifreeze. Excellent. And mostly children and alcoholics like it. Okay, also crush injury. This crush injury can happen because of car accident. It can be, during trauma, stuff like that. So basically your muscles will be breaking, releasing a lot of myoglobin inside of your urine. That myoglobin contains iron inside of it. It can destroy your tubules. If it destroys your tubules, it will precipitate to acute tubular necrosis. Also, hemoglobinuria. Due to variable reasons, we'll speak about it in hematology. And the proximal tubules is the most susceptible to injury. Please be careful about this point and do not get it wrong. Ischemia lead to dysfunction of both of your BCT and ascending loop of Henle. While nephrotoxin, they only affect the proximal tubule. Okay? Good. So let me tell you about one more concept. Diffuse cortical necrosis. Acute generalized cortical infarction of both kidneys. Both kidneys are messed up. What the hell can cause that? Well, it's likely due to combination of vasospasm and DIC. DIC is disseminated intravascular coagulation, a disease that basically lead to what? If this is your blood vessels, you will have a creation of a lot of microthrombi inside of it. Creation of this microthrombi will lead to thrombosis of so many vessels, so you have a hypercoagulable state. After having this hypercoagulable state, to make all of these thrombi, you needed a lot of platelets. So you had platelet consumption and the clotting factor consumption, the clotting factor as well. So you have less clotting factor, less platelet, that led to hypocoagulable state. The hypocoagulable state basically can kill you. Okay, so it's because of DIC and vasospasm. It's associated with anobstetric catastrophes. For example, abruptio placenta, which is most commonly due to hypertension. We'll speak about it in reproductive. And septic shock, in which we'll speak about in case of microbiology. And I would like to call it off for now, and that's it for today. I hope you like these concepts we spoke about today. I have a request from you though, guys. Tomorrow we are going to finish the pathology of the kidney. Oh, thank you so much. So tomorrow we are going to finish the pathology of the kidney, and after we finish the pathology of the kidney, on Monday we have the day off. You have the schedule already. And on a Tuesday, we are going to finish the rest of the system. Okay, great, guys. So I will see you guys tomorrow at the same... tomorrow 1 hour later. You know, every day we start at 6. Only on Sunday, we start at 7 p.m. Okay? So see you tomorrow, guys. Bye-bye.